You, sorry, everyone. Okay.
My bad.
And then, I like to do this because, again, like I've sat through presentations and gotten tons and tons of information and been really motivated during those presentations. And then sometimes it can be a little challenging, like the next day when I'm talking with colleagues and they're like, how did it go? What did you guys talk about? And I'm like, stuff, so my big takeaway is if people can just like actually leave this presentation knowing, heart disease is the leading cause of death in New Hampshire, which you may very well know already. I think the part that's lesser known is that it's really a leading cause of death among working age adults. So, and that's actually a change. I'll go over some data later on in my slides, but I find it deeply concerning that people are dying from heart disease at age 25. And so I do think it's a little bit of a reset on what we think when we hear heart disease. And that it really is quite serious. And then the last thing is just that you take away that the heart disease is going to be one of the department's major priorities in the next 5 years, which, I've been there, I'm a dinosaur, this is new. Even though heart disease has been around, it has not been a major priority of the department. So BPAW, we were established just this July in 2023. For those of you that are a little more like wonky around government, that's because we had a new budget and you need a new budget to create a new org unit at the state. But we were working on it for about a year before that, having conversations. It's worth knowing that a lot of our work is grant funded, and the federal agencies that largely fund us are the CDC and HRSA. Why I bring that up is to just kind of give the context of that a lot of times we get in our little world of like, the grant says to do this, I'm doing my thing, I report to the feds, and that's that. And we don't necessarily take the time to sit back and reflect on what is it that New Hampshire needs and how do I align my work with other things going on. And that's exactly what I feel like the process that I went through in the last couple of days really helped me to think through, and how the SHIP could be a tool for us so that we don't get into those little silos. Love to talk with people about the details of our areas of focus, but in a nutshell, we have a lot of stuff around disease prevention. Those are all the different diseases we focus on. A lot of our focus, and public health has been largely in this place for the last 10 years at least, is around early detection of disease. So things like cancer screenings, blood pressure monitoring. We've also gone a little bit into tertiary prevention or disease management. So really trying to prevent the further complications related to chronic illness. So helping people with diabetes self-management once they're diagnosed, or helping with blood pressure control. So those are sort of things we've been doing for about a decade. And then the newest part to me under this new bureau is actually a lot of work around primary care and rural health. And that's been a lot of focus on workforce. So we do the state loan repayment program for primary care providers. And then we do a lot of work around supporting the rural health care providers in the state. So critical access hospitals. We also do support the federally qualified health centers and rural health clinics. I'm going to show you the next slide, which looks really complicated and a little bit chaotic. And the sort of why behind that is it reflects that we are a new unit. And so we have lots of different pieces that have been in place for a long time. And we're really trying to do the work of figuring out the alignment. So this is us, sans SHIP. I don't expect you guys to like necessarily process it all. But it's just showing you there's a lot of breadth in the unit. There's so each of those blue boxes is essentially, and this isn't even perfect, that's a program, the blue box. And then within that, there are several different grants. All the grants have different priorities. So Alia's little box is community health. So she's up at the top. So she's got the state health improvement plan. She has a giant health disparities grant that's somewhat wrapping up. And then we even are working on public health accreditation. And that's just one little unit, but like many different funding sources and pieces. So I was really pleasantly surprised that being asked to reflect on the SHIP and alignment has helped me to actually think through some next steps with my team to get this a little less wild looking in the next year. just as a reminder, I know you guys all created this, but for my thinking around this, I didn't want to get too into the weeds of the ship when I was reviewing and aligning our work. So I really just thought of it in those 4 broad buckets of like access to opportunity, community, health outcomes, and then connectedness. And using that, like those 4 simple things was really, like, I feel like I can say I'm in my sleep. I've really internalized the ship. Oh, I went backwards. Let's see. Oh, we're going back. Here, try this. All right. So people who know me or have seen me present, I always try and bring something personal in because without it, some of you I've never met and I don't want to be just a talking head. But I also know for some people, data is not like super exciting. So I tried to honor Alya's distaste for overdoing the use of ships with the ship. But the more, as I reflected and had pulled together my slides, and this is usually how I prep my presentations, I put in all the detail and then I do the like step back, think about what's the theme. And I was really feeling like that the ship for me in some ways is a lot like a ferry. And so the first picture on the left there is a picture of me and my dad and my 2 kids. And we are in my favorite place on the planet, which is a little island off New Brunswick called Grand Manan. And the only way to get to that island is an 1.5-hour ferry ride there and back. And it's become one of my favorite things. It's something I look forward to on my way to visit and something that I really enjoy on the way off of the island. I think of the ship as a bit like a ferry and that like in the picture with my dad, you can see way in the background, there's the ferry. But day to day when you're there, you don't think about it, you don't get on it, it's not terribly relevant. Although we can see it from our house, and so you can actually tell time by it. And it's a small enough community, it's a rural place where you can say, oh, the ferry's not on time, what happened? And usually it's a health thing. Somebody, needed to be taken off island quickly. But in the background, it's actually keeping the community going. So it's bringing groceries over on a daily basis. And then also the primary industry there is lobstering. And so it's taking the industry off the island and getting us income to keep, people thriving. So on the one hand, I see the ship as like that. It's sort of in the background and it's keeping everything going. The other picture is just a picture that I took sitting on the ferry on my way back to the mainland. And I feel like the ship actually is a lot like that in that it provides an opportunity for reflection, right? So one of the things I love about the ferry is I can't go anywhere. I don't have anything to do. I can let my kids run wild because there's nothing that's going to happen. And I get an 1.5 hours to just sit and think and reflect. And usually I do that sort of, oh, the trip was so nice, this, that, really kind of put the bow on my vacation. And so for me, looking through the ship and kind of crosswalking it with my work felt like that moment of reflection. And so it gave me that opportunity as well. So the last piece is I feel like as a disclosure, I have to share that. So my dad in that picture died early of heart disease. He died suddenly of a heart attack in his 60s. And so I share that because I feel very passionately that it is not just heart disease. It's not just about eating healthy and active living, it's about saving lives. So it's very important. There. Full disclosure, I am serious about it. Thank you. Okay, so in part of the process of doing my slides, I went through each of the 4 categories and tried to find overlapping things that we're doing in BPAW that go with the ship. When I first went through, I only had that left-hand column, the now, and I was just thinking, I'm going to report out and tell you guys all the great stuff that we're doing. And I think that's really valuable. After I had pulled together my slides and I was thinking about it last night, I was like, you know what? I'm already starting to have ideas about like what else we could be doing in these areas. And I'll tell you the domain that I was the most shocked by was the connectedness. I was like, oh my God, we're not doing like anything. And this is so important. So I hopped back on this morning and added in like just my initial thoughts around things that we can be doing in the next 5 years to even have more work in these areas. And I got the idea that as a next step, I'm going to bring this back to my unit and we're going to have conversations about, what else should we be doing in the next 5 years? Let me check on time. Okay, I'm doing good. Okay, so just to give people a sense of A, like what we're doing in BPUB, but B, maybe to reflect on what your organizations are doing or what we might want to do as a council, I'll kind of talk you through some of the details of what's here. So public health has actually really moved in the last 10 years since I've been there upstream. So we have finally, even in chronic disease, moved away from that. I mean, we're still doing the stuff downstream because we know it's important. So things like disease management programs, early detection, even like healthy eating. But we've actually been challenged by our federal funders to move upstream to look at social determinants of health because we know that those drive a lot of different health outcomes. So for right now, we have really been actively working on screening for health-related social needs. And what does that mean for us at the health department? Because you might be thinking like, who are you going to screen? What are you? We really work at sort of a system level in trying to promote that type of work. So we're partnering with the federally qualified health centers to get their staff the tools that they need to be able to do screenings, helping them to think through what is the best screening tool. Something that we hear a lot is that like, yeah, that's a nice idea, but if I don't have really good training on how to ask somebody about their income as a medical assistant, they're gonna sort of say, why are you asking me? That's personal information, and I'm not gonna wanna ask again. So we're doing lots of work around how do you get people trained up and how to ask these potentially sensitive questions. We are working closely with Medicaid. So Medicaid, New Hampshire Medicaid just bid out their managed care contracts for Medicaid. And in the contracts, there's a requirement that every individual enrolled in Medicaid must be screened for health-related social needs. And we took it one step further this time around. So previously there was stuff in the contracts around that, and the MCOs largely said, we're doing that, which can be a little bit different if your insurance provider is the one screening you for those kinds of needs, as opposed to one of your care providers in the community. And so we shifted the requirement for that to be done by somebody local, ideally your primary care provider or their delegate, like a community health worker. So there's going to be a ton of work in the next couple of years. Medicaid knows it's not an easy, switch to flip to just get people doing this. So that's something where we're coming together and partnering on building capacity statewide. The next piece, because you might be thinking, well, it's great to screen, but then what? Is we have been very committed to supporting the closed loop referral system. I'll pause and let everybody roll their eyes because it's been bumpy. So if you have been following the closed loop referral system, we've had fits and starts in terms of our procurement. It is on track, I believe, to hit GNC in the next month or two. They've selected a vendor. But we know that it's not just, so we're supporting that, we're funding that. But it's also hard to just operationalize it. So just because we have a system doesn't mean people will know how to use it. It doesn't mean that it'll be integrated with electronic health records. So that'll be clunky for clinicians who are just trying to, quickly get through all the things they're trying to do with someone. So we're committed to actually helping with integration of that system into electronic health records. And again, doing training around infrastructure to support its use. Another one that this really ties to Jess Gorin's presentation last month about food and nutrition security and what's being done. But another huge priority for us is to be partners with the other department food and nutrition security programs, because we know that there are so many people that are eligible for those programs and they don't access them and use them for a number of different reasons. So that's another thing we've been actively working to develop referrals to. The last piece is community health workers. So within my unit, especially as part of the workforce efforts, we're doing lots around supporting use of community health workers. We used to do this in a kind of, in my opinion, a little bit of an odd way where we would fund them with like our cancer grant, but then they'd become very narrowly focused on doing outreach to get somebody to get their colorectal cancer screening. But at the same time, they knew that that person had all these other things that needed to be addressed. And we were sort of funding them with this weird funding that didn't allow them to be doing everything that was needed. And so now we've actually been able to broaden what it is we fund community health workers to do. So some of the things that I just got ideas for the next 5 years after having done this first crosswalk were We have a Healthy Heart program, but it's only in one site in the state. So that's free clinical care and free support for lifestyle change programs and disease management programs for people who meet a certain income eligibility. And I really think it's about expanding that program because we've been sort of content to say, like, well, it's here and it's working really well here, but I think we do need to broaden it across the state. CHW reimbursement, I think, is huge, both in that it will sustain that workforce, but also if any of you know community health workers, that's a group of people that don't necessarily have really high income, and under access to opportunity, we talk about financial challenges. And so I think it's like a 2-for. We're going to create a workforce that can support people around getting their needs met, and if we can elevate that workforce to actually have a livable income. And then even as I went through this, I was thinking like, you know, I would like to do a better job as an administrator at the Department of Health in terms of thinking about how we recruit people and making sure that we're recruiting from a diverse, you know, group of communities and stakeholders so that we are more reflective of who we're trying to serve. So that's something else I think sort of more internally we can do. I won't go into so much depth on each of these, but so community, this was really about like environment, healthy environment, built environment. So we do a whole bunch of different things on environments. We work on helping people reduce asthma triggers in their homes through home visiting. We do well water testing, a really cool project where we did like cross collaboration within the department was we did a program to get WIC enrolled moms to test their water, their well water for different contaminants. And then because we knew that mitigation systems can be really costly, but during pregnancy is a time when people are highly motivated to, you know, have healthy behaviors. What we did was at least provide them with pitchers, water pitcher filters that are actually pretty solidly good at filtering out contaminants. And so we have provided WIC moms with healthy water during pregnancy and taught them all about their water testing and how they can mitigate using a fairly affordable, you know, tool. We work on water fluoridation, so probably people don't realize it, but our oral health program has actually slowly been upgrading all of the fluoridation equipment in the state. So fluoridation was sort of popular and started back in the 50s. And as you can imagine, the equipment has progressed and advanced. And also the equipment that was purchased by municipalities has aged. And so we've been slowly going out and working with each of the municipal water systems to see what they need. We also provide training for those water system operators who may not have like a health background, but to help them to understand water fluoridation and the health benefits. We also, this is fascinating. I'll talk a little more about it, but so the tobacco program, which is under me, is responsible for enforcement of the Indoor Smoking Act. People may not be familiar with the details of that act in New Hampshire because it passed back in 1990. But New Hampshire is one of the only states that has a bunch of exemptions in the Indoor Smoking Act that allow different places to have smoking inside. And we're the people tasked with making sure that they do so in a safe manner, which, as you can imagine, is a tricky situation because according to the EPA, there is no safe level. So more to come on that. And then we used to do a lot more work in this area, which is why in my next 5 years, I said I'd like to actually reconsider applying for what's called the State Physical Activity and Nutrition Grant. People who have known public health for a while might know we used to be really into like building sidewalks and complete streets, and it's hard because it's working with different partners and it's really expensive and it's not our thing. Like it's like a little bit of a new thing for us. But I think it's really important for us to think about if that's something that we should actually build our capacity around and apply for in the future. We do a lot of work with trying to get some of our programs that are lifestyle programs offered in parks and like natural outdoor recreation spaces, but I think we can do a lot more. So next 5 years, like I said, apply for that grant potentially. Just think more and more about outdoor recreation, which I think was a great thing that you guys had in the SHIP, you know, to take advantage of that resource we have in New Hampshire. And then really revisiting the Indoor Smoking Act.
Can I ask a question?
Yeah.
on water fluoridation, your focus is on, obviously on municipal systems. Yet a lot of people are on private drinking water wells.
Yes.
And I'm on a well, rate for radon, no problem.
Yeah.
Arsenic, I've got 10 times the maximum level, so I have to filter
Yeah.
more.
You bring up it's a fantastic point. I didn't focus on that in the data part of my slides, but I'd love to consider having that conversation. So many people are not necessarily aware of the fact that New Hampshire, we rank 48th in terms of access to fluoridated water in the country. So we're pretty much the worst. But we also have about 40% of our people on private wells. A lot of other states, you're on a community water system. So we don't actually have a ton of community water systems that don't opt to fluoridate, although Nashua is one. And, you know, it'd be interesting to kind of think through that one. But I think, so what I always like to say is like, it's important that we think of multiple strategies around oral health and not just like water fluoridation is the most cost-effective strategy. But we also do at the health department have school-based oral health programs, and we fund community clinics for adults. Those school-based programs are really fantastic for caries prevention. So you have a dental hygienist go into the school and actually apply preventive care and do a little bit of restorative care and then refer to dentists. But again, that's not necessarily impacting, you know, adults who aren't in schools that don't have access to fluoridated water. So yeah, but it's an interesting contextual thing for New Hampshire that we can't necessarily use those exact same strategies that might work in a place where people don't have wells. Like when I go to national conferences, people are like, you have people with dug wells? And I'm like, yes. That my in-laws, and I'm always like, can we test it? Could we maybe? And they're like, no, it's fine. We're fine.
Tastes fine.
Exactly, yeah.
It tastes good.
Yeah, or my mother-in-law doesn't want to change anything because it would make her hair look different. So she's like, no, I don't want to treat it. It works well for my hair, so. Yeah, different priorities. So this is probably, again, like where most of our work falls. And I don't want to like exhaustively talk about it, but some of the things around health status and outcomes. So a lot of what we do still falls into that. Even though our insured rate is fairly low now, what is it, around 6%? So around 6% of our state population are uninsured, which is crazy compared to when I started, and I think it was around 13%. But we still have a whole bunch of people that don't actually have access to health insurance. And so the state health department funds in sort of weird different ways that have emerged over time and because of different funding sources. So we do free breast and cervical cancer screening and navigate people through diagnostic follow-up and actually can get people enrolled in Medicaid if they're diagnosed, which is great because back in 1990, when the program started, we'd diagnose people and then say, yeah, so that's like a major progress over time. And we've just recently been able to add in a whole complementary program around cardiovascular risk. So we now provide free screening for cardiovascular risk and then actual treatment for both the cardiovascular issues. And if people want to engage in lifestyle change and disease management, we provide that for free. A lot of our work is behind the scenes, just increasing access to community-based prevention and chronic disease self-management programs. We're hugely partnering with the Y. But another big piece of what we're trying to figure out is the Y is not really in all communities in New Hampshire. I'm painfully aware because when my kids were little and I wanted them to learn to swim, I drove 45 minutes to the nearest Y. Thinking why? No. And so we're really trying to work to figure out, there are a couple different models like Y Without Walls and Y Hub models, and also just engaging with partners in rural areas to get these programs and services out to the communities where we see the disparities related to these diseases. We do a lot around reducing barriers to making healthy choices. Like I said, that free program does a lot of that. So we make it so that gym memberships are free, like workout equipment is free. Another place where we've been very involved, and this has really been post the Affordable Care Act, when a lot of people became insured. CDC didn't reduce our funding. They just said, well, now that a lot of people have access to insurance, we want to make sure that their insurance is covering high quality preventive clinical care. So we went from providing it ourselves and funding it to trying to work with the clinics that served individuals who were newly insured to make sure that they were getting recommendations for their, cancer screenings, blood pressure monitoring. One of the kind of coolest things, this really took off during COVID, is we have done a lot of work around increasing access to home monitoring. So self-monitoring blood pressure cuffs were like a huge commodity during COVID because nobody wanted to go anywhere near their doctor. And yet people still needed to have, good clinical care. So we did a ton of dispensing of blood pressure cuffs. A lot, especially in maternity wards where pregnant women were just kind of scared to death to go anywhere, but also, if they had blood pressure issues, they needed some kind of care. And then more recently, this aligns with the SHIP focus around kind of workforce and making sure that the healthcare workforce is supportive of all different people. We've definitely been doing a lot around our workforce recruitment and training and trying to make them sort of more able to serve diverse populations like LGBTQ+ by providing training. Let's see. Expansion, just more integration with behavioral health. So that was something that stuck out to me from the SHIP. You guys had like an emphasis on comprehensive and listed all the different types. I feel like that's like, we don't do that as part of our free care, and I'm not exactly sure why. But it's definitely connected to heart disease. And so I'm already thinking about how we might make that covered under our somewhat restricted grant. Partnering with Medicaid. So those programs that I talked about that we cover for free for uninsured people, they're not necessarily covered by Medicaid anyway as a service. And so I think we can get creative about how we support people that have insurance but that do not have coverage for some of these lifestyle change programs and community supports. And then we're just expanding into some other free screening, including retinal and kidney screening, which we're seeing like kind of really concerning trends around kidney disease and retinal issues related to diabetes. And then even it's on my mind, it's newest to me, but the state loan repayment program and how do we recruit in a like sort of mindful way for a diverse group of clinical providers. So the state loan repayment program is for paying loans for lots of different provider types. So doctors, dentists, mental health providers, some types of nurses that are willing to work in underserved areas. And just trying to think a little more tactfully about what is it, where do we want to really try and get people from? Not just where do we want them to work, but how do we make them a good fit for the communities? Okay. So the last one, social connectedness, a lot of that for us, I think the best thing that I could come up with, because to be honest, I had one bullet here, and so which really did make me kind of sit and think like, this is the spot where we could really do a lot. We could really improve. We do lots of partnership building and collaboratives. So I think that that's the place where, I mean, this is quite frankly something that we support at the SHIP Council, where we're bringing people together and hoping to actually foster connectedness. We've got youth tobacco coalitions where we're trying to actually engage kids in helping to actually be the advocates and shape the work that we do at the tobacco program around preventing and reducing youth use of tobacco. We also have a New Hampshire Cancer Partnership that's about bringing together lots of diverse partners to implement our state cancer plan. And then in a sort of smaller way, we're even starting to fund and support ECHOS. I can't think of what the acronym is for, but probably many of you know it's a sort of mix of a didactic presentation on certain topics with then case consultation to be able to sort of get more and more capacity out to areas that may not have specialists themselves. So we're doing one of those around supporting cancer survivors in the state. And then actually, it's just one of those things, it's not necessarily by design, but a lot of our disease programs, like our lifestyle change programs and disease management programs, are delivered in a group format, and they do occur over many, many weeks. And so you do actually start to build some connectedness through those groups. And then I do feel like within our unit at the health department, we are really focused on trying to build connection, especially post-pandemic, as we come back into the office. So that's another thing I feel like we have to acknowledge. In the next 5 years, I saw there was an item in the SHIP around social connectedness and like healthy aging in communities. I feel like that's sort of like, yes, obviously with chronic disease, that's a part of it, but we haven't necessarily worked in that way with intentionality. So I'd like to like do more connecting with aging groups in the state and to think through, like, again, I think we've always said chronic disease is a disease of aging, but we haven't necessarily connected and thought through that as a target population. Screening for social isolation. I don't know that that was actually on our list for social determinants of health, but it's definitely something that's now on my mind. We don't collect that as part of our regular data collection. I think it's that tough thing of if you screen, then you want to be able to do something. So, but again, now it's on my mind because I'm thinking like this is huge and this actually drives a lot of these different chronic illnesses. We do have a lot of data systems. So we run the cancer registry for the state. We help support our behavioral risk factor surveillance system. And I want to review that with a lens for some of the charge that you guys had around social connectedness. And then I loved the one about, there was something in the SHIP about developing volunteer opportunities. I think if we have that as a goal, we can do so much around that. When I started 10 years ago, we used to have volunteers that helped with our free screening program. They just were passionate about helping prevent cancer and they would come and they'd do mailings for us. And over time, we just kind of let those things fall away, whether it was because HIPAA made it hard or whatever. And so I think it's very actionable for us to do that. ALIA has also been a major advocate for us as a unit to start to engage more in volunteer opportunities too, which I think is another thing we can do. All right. So that was my brain dump on BPAW and the alignment with SHIP. And I do want to thank you guys for inviting me to present because I don't know that I would have done that without, sort of the call to do this presentation. And I feel like it was really helpful. And like I said, I'm going to go back to my team and use that as a framework for our thinking about getting that mush graph a little more streamlined. So switching gears into what is the department doing, not just BPAW, and it will not be that extensive because it would be forever. So just as a reminder, Tricia presented earlier, Tricia Tilley, our former division director, SAD, current associate commissioner at the department. She had presented to the council a little while back on what DHHS is doing. So DHHS for 2023 had this sort of high-level plan called the roadmap that the commissioner really wanted us to have. These were the 4 things, the 4 big areas in that roadmap. One of the areas was promote thriving communities. And that is where the SHIP fell within our department's roadmap. Under that goal, or under the thriving communities, we had the goal of finalizing and launching the SHIP. So that has been done. Yay. And then the second part of that is that we were tasked with broadly communicating priorities. The priorities were ideally going to be evidence-based. They would be priorities that really needed integration across the department and would leverage resources. And so we are on the hook for February 2024 to have that, which is now. And yeah, and happily, again, I think he's still on, but I do want to acknowledge, so Dr. Chan is on and has started coming to these council meetings. He has been gracious enough to say that he would like to participate in that sort of internal discussion about how do we as a department move forward 5 priority areas. ALIA has been largely involved in that and helping to kind of shepherd us. And I know both she and I are going to share those like very high level priorities that we have figured out, one of which is heart disease, which is what I'm going to get into. I'm going to skip over that because I'm running late. So these are the 5, and this shouldn't be new. I believe Tricia has somewhat shared this with everyone. But at a high level, these are going to be the department's 5 major priorities. Honestly, actually, no, these are a little bit surprising. I was going to say they're not that surprising, but they're a little bit surprising. I find heart disease surprising. I find sexually transmitted infections a little surprising. do you have any like reflections on the priorities? Oh, yeah.
I have
Yeah,
lots, but yeah, I think there is some really excellent work that has taken place around the state, around a lot of these. And the department has begun investing, like dipping their toe in several of these that we've seen, but I think it will be nice to have kind of a more integrated movement toward.
and I think we tried to kind of balance the big with like the possible, like that's the real tension, right? You want to be aspirational, but you don't want to be. And so I'll talk a little more about even like within heart disease, what's achievable in 5 years? But yeah, so for better or for worse, I mean, I'm excited. I think there's breadth. There are some things in there that are new, that are unusual, super important things. Okay. So this is probably really tiny for people to see, but in a nutshell, the graphic is one I stole. I've got the citation down below. Actually, and I not only stole, but asked all you to find for me. So they could do that. I was like, it's got skyscrapers and it talks about the continuum. But I really feel like this is a good visual of, so outside that sort of box that I put over it is the sort of what you think of when you probably hear chronic disease and health department and health promotion. So that's really like talking about individual risk factors and disease occurrence and mortality. And that's where we've tended to largely be over the last, 15 years, where we talk about disease burden and risk behaviors and health promotion. We are moving way more into the box that's around living conditions, institutional inequities, and social inequities, and that feels completely aligned with the SHIP. So I feel like you guys kind of did the work for us of like, what's our tool gonna be to get us a little more up here? So I just shared that because I just feel like it was a slam dunk. And then this quote is from a National Academies of Science report from 2021, where they pulled together a group of stakeholders to look at the increased mortality rates among working age adults. And not that this isn't obvious, but I always feel like I need to remind myself when I start to look at data and I look at mortality data, I can oversimplify, right? Like, so you're like, oh, lung cancer, like, oh, that's probably related to tobacco use. But really mortality is the result of a whole bunch of things, including, social inequities, like institutional biases, long-term things that are occurring and short-term things. So I just wanted to kind of put that out there as an important context. All right, so for all my data junkies, which I love data, I'm going to go through some different pieces of data. So this is kind of complicated, but I wanted to capture a bunch. These are the leading causes of death in New Hampshire. I put data from 2000, which is the purple bar, and from 2021, which is the olive bar. So a couple of things to note. Heart disease is #1 leading cause of death in New Hampshire. I can tell you because I've had both the cancer program and the heart program in my shop for years. They go back and forth, and then the cancer program goes, we're #1. And then next year they're like, oh, heart. So it's kind of like a negligible difference. Yes,
Oh, I'm sorry, where's drug overdose on this list?
that would be accidents. Yeah, so, which is great, because when I first saw accidents, I put it in our group chat for work. I'm like, please tell me this includes drug overdose, because what are these other accidents? And that was confirmed. So you can see that, and I bolded that one. The olive bar is 2021, so you can see that's gone way up over time. And again, I think this group is well aware of the impact of, the opioid epidemic on that. You can also see, and again, not surprising, COVID-19 suddenly is on there as #3. I'm told it's dropped down to #5 as of provisional data for 2022. But you can see where it kind of fell in the list. I put boxes, a couple other things I wanted to highlight just for the broader SHIP context. And thinking about the state health assessment, I found it really concerning to see the suicide number go up. So I have that one bolded. You can just see it's going up. And then chronic liver disease and cirrhosis is going up. Now, go back to my quote about mortality, don't jump to conclusions about the liver disease and cirrhosis and the cause. Because I don't know if I talk about it later on, but we know there's actually a connection between diabetes and non-fatty liver disease. So it could be a bunch of different things. It's messy, but again, like for me, as somebody who's looked at mortality data for years, those are things that popped out. Like liver disease didn't used to be on the top 10. It wasn't there. So the boxes I put around what I think of as cardiometabolic diseases, which all really kind of have those shared risk factors. So I put the shared risk factors over there. And I'm gonna dig in a little bit to heart disease data and then some of these shared risk factors just to, and I'm putting this out there as like, maybe we want to pick some of these things to add to the SHA, or maybe it's just good context. Any other questions or comments on the mortality
I
data?
was just gonna say, because the lens that I come from is the substance use disorder world. And so when I see the intentional self-harm, the suicide, and the chronic liver disease, both of them spiking in 2021, I immediately went to COVID-19, social isolation,
Yeah.
anxiety, depression. And so our alcohol consumption was exponentially higher during
Yes.
that. And so like, yeah, cirrhosis and suicide, but those went along with
Yeah,
COVID-19 and alcohol consumption. But that's my lens.
no, well, and that was my first thought. I was like, okay, that is what it is. But I think you can kind of see there's like,
And I think the clinical folks, not to get ahead of them, but I do think you hear from the clinicians who are seeing folks like in the ER and that is what, they were seeing a lot, particularly on the alcoholism side and some of those, both the acute piece, but also the additive chronic alcohol abuse kind of stuff.
and for a little bit of additional context, that National Academy of Sciences group, they did a lot of like digging into the data around the rise in working age mortality. The three drivers of that rise were, not surprisingly, drug-related, suicide, heart disease. Not to like pit favorites or whatever, but sheer number was heart disease. But again, those are the three drivers. And honestly, heart disease is also driven by substance use. So you can't really say like it's one or the other, but those were the three, and that's really, really scary. Were you gonna say
I
something?
don't want to interrupt you too much, but one of the leading causes of a rise in anything is a failure to recognize it previously. We know that from heart disease in the 50s. We did a lot of work on drug overdoses and failure to recognize the percentage of them were due to suicide, not due to an accidental overdose. So I mean, we really encouraged the people that assess death, those guys.
Medical examiner?
Yeah.
Yeah,
You know, to really look more broadly and not just assume something's an intentional overdose and that. I mean, cirrhosis and liver disease takes years to develop. It's not something you just drink now and you're dead tomorrow. It's,
exactly.
You know,
Well, and I think the other, so in some of my darker moments, again, as the chronic disease director, I'll tell some of like people, I'm like, you are gonna die from something. Like, I'm sorry, but that is a condition of life. But you don't necessarily have to live with the thing for a really long time before it happens. And so, like, to your point, it's like, even if we do work on this, eventually people will die from something. It may very likely be heart disease, which could be like a great, again, like if somebody's well into old age and they don't have a prolonged illness. But so again, like this is just, I'm glad you brought up the medical examiner, because the other thing I didn't put on there is that almost half the deaths in New Hampshire are unknown. So take that for what it's, and that's just because they're not quite, it's not easy. It's not like somebody rolls in and you're like, okay, I know exactly what happened here. And so that's the reality of our data, right?
they're funded and understaffed.
Yeah, it's tough.
And Whitney, and just to go back to where you were, you had the box and focused on the social isolation. That's where you can see a huge, where social isolation plays a huge role in some of what we're seeing as well. So that connectedness is really, really important.
Mhm. Yes, I agree. All right, how am I doing on time? I think I'm like at time, right?
Well, how long do you need off?
Okay.
I mean, we have another hour for the meeting and
Okay.
Molly is the only other presenter, so we don't have anything else we have to get done.
Okay, well, you already covered this, but I was just gonna remind people, state health assessment, love that it has some chronic conditions in it. love that it has some of the places where we're seeing disparities in those outcomes. So I just highlighted, you guys kind of nailed it. Rural communities, we're seeing disparities. Working age people, which you guys actually had flagged under diabetes. And then I don't know exactly how you want to word it. You guys had income less than 25,000. But low income individuals, like those are the places we're seeing disparities. And so you guys have that, and I just figured I'd provide a little more context. So this is really hard to see, but you don't need to see too much detail. It's more for that big picture look. So this is trends in heart disease for 65 plus. Red, dark red is most concerning, blue, dark blue, least concerning. So for 65 plus, things are looking fairly consistent over time. This is from 2010 to 2019. And you can see New Hampshire's not really popping out as like anything too bad. Although if you look really closely, there are 2 red counties, and I'll zoom in. So don't hurt your eyes. So this is the zoom in. So 65 plus, I've listed out because I know not everybody, although my husband's always impressed since I work at the state, I'm like, you don't know all the counties? And he's like, what county are we in? So, but I put those there, I listed them. So the counties that pop out for the highest death rates for 65 plus for heart disease are Coos, rural, Belknap, also somewhat rural. But the more concerning indicator to me is the others. So this is the blue and red map. That's the change in rates of death. So the darker red is somewhere between 5 to 15% increase in the death rate from heart disease in Carroll County and Stratford County. So that's just, those are some other things we could think about in terms of the state health assessment. So now this is the young people. So this looks a lot more red, right? So this is trends in heart disease among working age individuals. And the dark red and the light red, that's like anywhere between 5% to 20% increase in the rate of heart disease among that age group. I think we had some really good discussion about some of the reasons why, but it is really concerning. So here's the more detail around New Hampshire. So you can see, once again, Coos, even though I certainly have a tendency to think, oh, Coos equals older rural population, but here we see actually heart disease is increasing among younger people in Coos as well. And then the really concerning part is again over in the Carroll Stratford County, that they're experiencing a 20% increase in the death rate from heart disease in working age adults in New Hampshire. So that's like a real area to be thinking about.
Okay, I just have to say, for those of you who've been doing this since 2018, which is Daisy, Bobby, and some folks on the phone, several of you, Katie.
And Charlie, who's going to kindergarten next year.
And other rest, right? For those of you that were not, when we started this in 2018, I think it may be our 3rd meeting. Yvonne Goldsberry said, "We cannot forget what is most commonly killing us, not just the thing we talk about the most." And she said, don't ignore heart disease. So I just wanted to give some cred for a 6-year-old conversation that happened.
Yeah.
When,
Well, and I think it has this stigma as being like an older, you know, it's like, it's what happens, but it's like,
Right.
it's not.
well, and it's like, it's inevitable, right? I think that's what
Correct.
we have this like, I think what Yvonne was trying to remind us of way back then was just because we've talked about it for a long time, just because we talk about it in high numbers, does not mean we can't do anything about it.
Right.
I think that
Right.
was what she was trying to remind us of. So I just had to say, like, for those of us that have been doing this for a long time, I feel like I'm right back in what a round building conversation way back in the day.
And the other piece that is why the department has chosen it as one of its 5 priorities is it's also really not easy. It takes a lot of different people. So let's see. So I wanted, oh, yeah.
I think it's unfortunate that Phil Sletton's not here because he would be loving this.
But he's on vacation. It's okay,
And
Phil.
Joe
He's gonna listen to
remembered
it later.
record. Yeah.
I have to wonder what is going on in Carroll, Belknap, and Stratford counties.
I mean,
Why is this happening?
I mean, because, so I live in Belknap County, I work in Belknap County, and all I can think of is my staff member who has survived, I think, 11 overdoses.
Yeah.
And his diet is horrific. He's 29 years old, and I'm just like, no.
Yeah.
That heart disease is what's gonna get him.
Yeah.
So I don't know if it is because we just have such high, I mean, the nutrition, I mean, this is just, nutrition in Belknap County is awful. It's like just fast food.
I think you've,
But that's statewide.
Yeah.
Why these three counties?
well, I think, sorry, I want other people to tell you.
I think, well, one of the most interesting things I've ever seen ever was the charting of overdose by county in the entire United States.
Okay.
And Belknap County is way up on that, and it's a vicious cycle. And we have a huge problem with that, especially in Laconia. I live in Belknap County.
So, and I would share anecdotally, so at one point I was interviewing an exercise physiologist for a position at the department. And I was asking her about like why she wanted to come work at the health department. And she said she works in a currently she was working at a cardiac rehab program, which is for people after they've had some sort of, heart-related issue. And she said, the job has completely changed. I'm now having young individuals come who want to figure out how to actually be healthy. They've overdosed, like they've had this history of drug use. They're totally motivated to actually turn things around. And I have to help them think through, how do you safely exercise with, and it's very different than before when she'd have a 70-year-old who's like, I'm gonna go for a walk. Like, she's like, these are people that want to go out and do high intensity training. Like, it's a really different population. So I do think that's a piece of it. I am gonna walk through some of the other things that are drivers that might give some context too. So
And Representative, or Senator Birdswell, did you wanna ask your comment verbally? I see you in the chat. And I see you're off mute, so I give you the opportunity.
I just wanted to, has anybody looked into the fact that the increased use of cannabis is a contributing factor to all of this?
no, I don't. So, go ahead.
That's an unbelievably good question. We've talked with the people from the offices of restorative justice, and they look at the gateway drugs that we're really worried about. And they said it's alcohol and cannabis. And everything you've pointed out on these screens right here, I mean, it may not be the problem by itself, but it is leading to these other problems. And we're seeing probably an epidemic of cannabis use disorder that we really need to be aware of, because it will affect everything that you're talking about today.
That's what I'm afraid of.
Yeah.
I was just gonna add, working in social services in Belknap, Grafton, and Carroll County. A few things. One is this is a fascinating conversation when I just caught a glimpse of the news this morning talking about putting pressure on your Dollar Generals and those types of stores. I don't know if anybody caught that, but actually they're trying to get legislation that probably was in California to actually require them to carry some percentage of fresh fruits and vegetables, because what's happening is, so my mind's kind of racing. Years ago, we sat through demographic presentations where we knew that those counties are the counties that we were going to be left with the poorest and therefore the neediest of our communities. And that's exactly what we've seen in family resource centers and other services. Then you take those and those types of places, whether it's fast food or your Dollar Generals, I've watched it, and they move into the poorest parts of town, closer to where you've got families who are walking because they don't have transportation, and they're getting their groceries at Dollar General. And I live in Moultonborough, and it shocked me when I found out. I was so against the store coming to us anyways, and then found that's exactly what they did. And the families living in that area are walking there to get their groceries, and you can't get much nutritional at a Dollar General, but that's what's affordable. So we're keeping them in that. You add that, the other thing my mind jumps to is the free and reduced lunch percentages in the schools in those counties. It's horrible. It's shocking. People in Moultonborough think that we're a rich community, and 60% of our elementary school qualified for free and reduced lunch. And this was a few years ago when I heard that statistic.
Yeah.
So all of those things to me just go, oh my gosh, yeah. So there we go. It's showing up beyond obviously substance misuse and other issues.
Yeah.
It's showing up in those because it's starting young. It's in those families.
And I'm glad, I forget what term you just used, but it's like, that's exactly how I felt as I went through the ship. I'm like, oh, there's all these like I'm kind of getting fired up to like actually make a change related to heart disease, which to Joe's point, I think we've been talking about it for a while and it sort of almost feels intractable, like you're like, it just is. I want to be mindful of all your time. I have I'll go through quickly and just highlight, because I don't think the blood pressure it's a sort of step, right, towards heart disease. And we do see, we're not the worst, but we sort of pop out. So New Hampshire is a little bit worse, certainly than our neighboring states in terms of blood pressure rates, particularly in that working age group. And that's something that is really easy to sort of treat and control. Prevention is also like ideal, but again, for people who are actively walking around with uncontrolled hypertension, there can be something done. If we're thinking about target populations, 2020, we saw a major drop in blood pressure control among our Medicaid enrolled population, but then overall, only around 60% of Medicaid insured individuals have their high blood pressure under control. So that's another easy place to do some short-term work if we're looking at 5 years. We've talked about this a lot, but I just wanted to share for people. So diabetes prevalence, it's going up, not hugely. And you might say, oh, only 10%. When you break it out by income, you start to see what people call a social gradient, lower income, higher prevalence of diabetes. So there's a place where I feel like the ship very clearly sort of says, like, this is a place where we need to at least address that inequity. Alcohol use, we've all just talked about it. You can cut the data a million different ways. This isn't my super area of focus, but I did just kind of circle around, like certainly New England, we are an outlier in terms of our alcohol use. The blue being the higher usage. I also put, because it's winter, I put that oval around the northern states and was like, climate, health, like, I don't know. It's
Hot toddy by the
dark.
fire is a thing.
We need to stay warm.
I thought that too. I'm like, is it Canada's fault? Because as you know, my beloved place is in Canada, so I don't know. But anyway, yeah, this is certainly something that is contributing to heart disease. Tobacco use, I think for a lot of people, it feels like we've done that, we've fixed that. You look at our overall rate, it's 10%. Like what more can we do? You look at it by income, and that is a perfect social gradient. The lower income is almost 30% of people are smoking in New Hampshire, compared to like 3% of higher income individuals. So this is alive and actively a problem. So in summary, to finish out my ferry analogy, yeah, I had to put it, by the end, I was like kind of humming the Queen song. I'm like, yes, I'm bought in. And I feel like, you know, again, to extend the ship metaphor, like we have driven BPAW and the department onto the ship, and we are like big partners for the next 5 years. So,
And Bill Palmer has a question also, so
Oh,
let's let
okay.
him chat before.
and I'll put up my contact just so he's got it.
Bill.
Right. So Senator Birdsell's question was, as Dave said, a really good question. And I said to myself, I have no idea. So I looked up, and there is a University of Colorado study. I picked them because they've had legalized recreational cannabis for about the longest. And that study doesn't show any increase. So I think we need more data, but it's going to be interesting to see what really comes out of it.
Yeah.
And I think,
The healthiest states too, though. I mean, everyone's a triathlete out there and using cannabis, so it's not like.
so I remember when cannabis passed, and I was out at a conference in Colorado talking to somebody from their health department. And they had said that one of the things that they had put in place when recreational cannabis was passed was to develop better surveillance systems around understanding the health impact. And so that might be one of the things, you know, to think about when and if recreational passes in New Hampshire, is how do we want to try and monitor and protect health? Because again, if you can't have data on everything, but if you don't have data, it's really hard.
I have, can I ask my question? Yeah, I mean, just relative to cannabis, it's not a problem until you diagnose it, and it's way underdiagnosed, I guarantee it. Most people, when I'm Dave Nagel, I'm a physiatrist. Most people They think of me, they think of pain, but I was actually brought to this state by Easter Seals to create models of care for people with spinal cord injury, head injury, and other things. What's concerning me and what's not in this is how we're dealing with complex disability, biopsychosocial.
Yeah.
And I think one of the things that I could ask you a million questions, I want us to keep that on our radar. Cause yeah, there's an acute element, there's a long-term element. These people have to live with this stuff the whole rest of their life and they need support for themselves and their families. One of the things that's really missing in our healthcare right now is how we integrate treatment models and how we create it in a cost-effective manner. That's the critical thing. And I would like us to keep that on our radar is how do we treat complex medical problems in a cost-effective, integrative way?
I'm glad that you said that because, I might be saying, I may think I'm creating something that already exists, but, I was reflecting on just what you said about how nowadays it's very unusual for somebody to have one chronic condition. So that's another thing we're seeing increase, but also not just chronic conditions, but other things that are going to impact their health and well-being that they're dealing with at the same time. And I know that the term like intersectionality has been used to describe people who have multiple different like isms that they're experiencing. And I almost feel like we need to actually start thinking from the perspective of intersectionality in terms of like, you may have a disability and a chronic condition and a mental health issue and a substance abuse issue, and you cannot do one thing. They have to be all together. You've got to consider them all. All right.
Thank you, Wendy. But I do think that that's actually one of the reasons, in the SHIP, creation, I think the groups struggled, if I recall, to sort of figure out where to put the integrated care, right? Because it crosses all of those pieces. So I think we put it in a place, right? I think we put it in this chronic disease, health status and outcomes place, but it could have been in any of them.
Yeah.
And it should be, obviously, in all of them.
And I think it's that we have to change the way we think about things, right? Because you're right, when people present, they don't present just in that one box.
Right.
And our systems are not set up to deal with that intersectionality. They're not. And in fact, our system has barriers to actually prevent people from getting the services that they need when they have all of those different conditions.
And our payment systems are huge.
Yeah.
Because they want us to have one diagnosis,
Right.
not multiple, and they don't want you to have one kind of care, not one.
There we go. Sorry about
We're
that.
back.
My apologies.
All right, so when we were talking about what the next steps are, we really thought it was important to start to think about, okay, how do other organizations besides DHHS, who is and should be focused on this all the time, think about integrating state health improvement plan opportunities into their work. So I'm just gonna go with some very concrete examples today. And Whitney and I's presentations overlap quite a bit in terms of DHHS, so just bear with me a little bit. No. Okay, so just a reminder, I'm gonna reflect on something that I've used before, but in order to get the SHIP app actually implemented, we do need to create these network nodes. So those are the big, and those in the room, it looks like black, but they're purple, big purple spots. So trying to figure out who's already doing the work that is named in the SHIP, what are they doing, how we can start to connect and engage with others and actually create something that is greater than the sum of its parts. So, and then we need to be able to track what's happening. So this is something to keep in mind as I start to talk about a very specific example, but really we need to think about how do these things all connect, just as we were just talking about the intersectionality of care. So as you are sitting either in the room or at your Zoom or laying down in your bed if you're not well, because we have several of you on the call, Thinking about what you as either an individual or an organization or as a member of a collaborative are already doing that fits into this framework, then choosing how you align with it, selecting how you're gonna figure out if you're making any impact at all, and then the collaboration, and then creating change as those champions that you are. So this is that like really basic level of how could somebody integrate with access to opportunity if you were in the healthcare world. So in terms of that, and it's a teal circle on the right for those who are in the room, expanding efforts to improve nutrition security and promoting healthy dietary patterns. You could be screening program participants if you are in a community organization that's healthcare, trying to figure out if people are food insecure, have an available listing, or providing program participants with some basic nutrition information. I'm thinking about somebody like a primary care provider. A family resource center and ensuring community spaces and resources are accessible to all can be looking to create some organizational practices to adapt to non-English speakers. Could be ensuring that your materials are accessible by individuals who have low vision needs. So it could be a screen that's available in your office, like a tablet to be able to enlarge things, or having a larger print available, screen readers, etc. So I'm gonna go a little bit more into the 5 DPHS priorities. So we are settled on those 5. It's the heart disease, pregnancy and childbirth, childhood mental health, decreasing STIs, and substance use disorders. So those are the 5 where DPHS is gonna focus. Sorry, DHHS. I put DPHS because that's my frame oftentimes, but it is a larger DHHS focus. So we are creating goals, as Whitney talked about. There's a trifecta of us that are working on creating goals that align with those priorities, and then defining some SMART objectives. So in order to do those SMART objectives and goals, we're going to be working with the subject matter experts. So if you're in an organization and somebody is a clinician who works specifically with people who have substance use disorders, you would want to go to that expert instead of, making some assumption as an organization. So you can also refer to these Healthy People 2030 indicators, leading health indicators, for some suggestions. That gives you that kind of high level overview of what are some of the priorities across the United States. And then you want to have those objectives that will measure change. We are at the department going to create a tracking dashboard of some sort, and that work is still in process of how will we actually do that? How are we going to integrate that? Is that going to be a public facing website? Is that an internal tracking? Is that both? Is that all of it? So it is a lot of trying to figure out what those indicators are first, and then thinking of how do we kind of project that out.
Ali, do you want us to save our questions till last?
You don't have to.
So when, on that slide where you talked about this, the subject matter experts, will the consideration also be given to those who also have lived experience? Because sometimes we as providers have our ideas of how we should meet certain objectives and setting certain ways that we do that, but sometimes those with lived experience can also give some good insight into what could possibly work for them, because right now, and I'll say it a lot of times, things that we have set up in our systems right now are not working and are creating more barriers.
Yeah, and I actually would put somebody with lived experience in that subject matter expert category. I guess not everybody would, so that was an assumption that I made on that part, but I really do feel like that root cause analysis, when you really think about, well, you know what, I remember being in a meeting earlier this year and somebody said, I don't understand why people don't just take their blood pressure medications. And I was like, la, 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 as somebody who has a thing of pills that I lay out all the time, right? For myself, for my daughter, and we have multiple chronic diseases. We're trying to battle all of those at taking the pills at the optimal time of day, et cetera, refilling them is not financially a problem for us. Luckily, I'm very lucky. But there's a lot of other context that's happening. And some of that work that Whitney was talking about with home visits and the mobile integrated healthcare initiatives that we've done have really started to illuminate, not just for us at the department, but also even clinicians, like, wow, there's so much going on behind the scenes there. And I think we had some understanding about that a little bit when a lot of visits switched to virtual. People all of a sudden got like, take the curtain away and you could see what was going on behind a patient, but at least in a healthcare setting or a health, public health setting. But yeah, I really do think that it's bringing in multiple points of view and understanding that every individual is not gonna fit into that nice little box to control. So if we were to take the example priority for DHHS as heart disease, and this is not necessarily what we will settle on, but this is just a really concrete example. So if the goal is to improve and reduce the levels of heart disease across the population, potentially we would look at that reduction of the use of tobacco products. So an X% reduction in teen reports of vaping, and then tracking indicators over time. I stole this from Vermont, this particular tracker, but this was an example of how we would kind of look at that data over time. And potentially, you know, whatever tracking or dashboard metrics we would use. And then right now, our regional public health networks are all starting to turn in their community health assessment and community health improvement plan reports on their first quarter of, or their second quarter of work. And so they are also creating work plans that are tying into the SHIP. So I wanted to grab one of theirs and one of the areas that they are focused on for a particular region. And just give this example of they are also public health focused at the more regional level. So they were asked to take an area of the SHIP, figure out how their work fits in, and then start to talk about how they address that. So one of the strategies that somebody chose was lead and participate in regional collaborations that promote nurturing environments that enhance health and wellness across the lifespan. And that relates to the SHIP part where it says everyone is able to receive care that's affordable, high quality, comprehensive, inclusive, and delivered by a person-centered. And of course, I can't see what the last thing is, but you get the idea. And so one of the regions is doing expansion of resources to support caregivers' capacity for social and emotional development of their children. So the way that they're doing that is actually, they have these welcome bags that I thought were really cute to even just read about the one thing, but it's a baby talk, read, sing bag that has some different ideas on how to engage your child so that you can start to develop some of those pieces of their emotional and social learning. And so they're partnering with municipalities and also childcare centers to deliver those bags. So that's an example of an output. There would be a measurable indicator that they can settle on. That wasn't what the point was of this exercise at this time, but that's something that with the regional public health networks we'll be developing with the Public Health Advisory Council leads over the next series of meetings. So
on that program, is that the Welcome Baby, or are you saying it's an example of creating a Welcome Baby? Because there is a Welcome Baby program in New Hampshire.
Probably the Welcome Baby program in New Hampshire, because they are also, right, so most of the regional public health networks are also the early childhood, I can't remember what we call them, early childhood regions. So this regional public health network does the early childhood region development work too. So, but that's an example of, right, that's their work overlapping, but also ties into the SHIP work, so.
So your family resource, like we do Welcome Baby for our regions and we're
Okay.
the Winnipesaukee Public Health Network, so maybe it's coming up through that data.
Yeah, possibly. This is one of the lovely things that I get to do is like read it from a 30,000-foot level, right? But it's also really cool to see all the partnerships because they do in a different part of their work plan, they show the different partnerships that they have. I didn't settle on this particular thing, but that would, I mean, that's like a network node, right? They're the cross-sector partner in that work, so. So what I want to kind of set in your brains, and I stole this idea from Whitney, was thinking about how you're gonna champion the work in your organizations. We're hoping in the next couple of months to actually get ourselves all together in person in a way that we could actually start to almost have a work session where we're sitting and saying, okay, I'm an individual in my community. I work with the following partners. Here's how I can actually start to create some of the work of the SHIP in that area. So everyone has the fire, but the champions know when to ignite the spark. So this is our moment to try to start thinking, how do we light just the end of that wick so that we can start to make change.
Can I add in, like, as someone who just kind of went through the mental exercise of becoming a spark or whatever, I guess I just want to put it out there that like, I think it's hard, like it's big, and I don't know about you guys, but when like I look at the state health improvement plan, I get a little bit overwhelmed because it's big. And so I think that's part of what we're hoping to get input on is like, what would be helpful to overcome that? And whether it's a workshop or I don't know that I gave enough credit to you, Alia, but like, I went to Alia and was like, I'm feeling a little bit overwhelmed, and she was helpful to just kind of talk through like, nope, you're headed in the right direction. And I think she is a resource for anybody and any organization that's wanting to do this exercise. But again, I think that's part of the conversation is what else would be helpful? Is it dedicated? I do good with like a dedicated deliverable. Otherwise it's on the to-do list, like, oh, I'll do lofty thinking later once I get through the list. So I don't know.
So I know that we have, Rachel Dobby has put together some material that are gonna be in the review list for, DPHS to figure out if those, can be helpful for people, but is there any other things, would you find it helpful to be in a room with others as you're kind of like having a work session through this thought process, or does it still feel very vague and intimidating? Yeah.
You know, I've been involved in a lot of programs in my life, sit down, ad hoc, everybody's in an equal playing field discussions with clear, measured, this is what everybody needs to do when we leave the room type thing. That is the best way to do anything, in my opinion. Am I wrong?
I don't think so, but I have the similar brain as you.
Just like it when everybody's on a level playing field and around at a certain table and we can all just sit, discuss and I mean, we've put together 5 pieces of legislation the last 2 years by doing things that way and all have been meaningful. And I just think this is perfect for that.
Yeah, and it's also in one of those situations where if you're getting stuck, there's another person next to you doing that same exercise. And to be able to say, oh, whoa, I am stuck here, don't know where to go forward, and then kind of hear some of the inspiration. It's been a different exercise for me to sit with Whitney and Dr. Chan as we're going through how do we think through the DPHS and DHHS overriding priorities, and it's very different. It starts to get more information kind of flowing through your brain instead of wow, I could do anything, all the things. So.
I think for me, the group that I see being most beneficial to sit down with are the directors from the other RCOs. because I'm one of a larger network. And so although I could go through and say, this is what my organization can do, I don't want to speak for the other 19 centers. But I think as a collective group, and we do meet regularly, and if we had somebody facilitate that, we could, the RCOs hit the whole state, so we could, you know, champion that work as an organizational network.
So maybe group meetings that talk about being a champion for people who are in like-minded or similar professional experiences.
Right.
Right, so having, so like, I think that's what you were trying to do with the regional public health networks, as as a group of folks who have similar experience, a similar overall responsibility from a functional side.
Yeah.
Similar to this, similar to, and it's interesting because Katie and I were going back and forth a little bit, thinking about what the March meeting should include. And one of the things that I wanted to vet with this group, so I'll do it now, was to think about, you know, we've got a couple additional topic areas a few additional topic areas we haven't touched yet. One of those was just the social service infrastructure. So you may remember on the Shaw and then certainly in the SHIP, one of the things that we brought forward is, you know, we have regional public health networks, we have service links, we have family resource centers, we have CAP agencies, we have, right? So in New Hampshire, we have a lot of regional approaches to certain service delivery, each of them managed by a certain set of structures. Some of that financial, some of that legislative, some of that. And so we were thinking that maybe one of the things we could talk a little bit more about as a group is bring some of those groups forward and talk about how are we funded? You know, what does that look like? What are we allowed to do? What are we not allowed to do? Like, when do we bump up? And I know the doorways conversation was a great start example of this, right? Where we sort of like, would love to be able to talk about alcohol, right? But not allowed technically. So so I think, again, sort of figuring out if you're a person, like most people, and you have 5 needs, what are you probably doing? You're talking to 5 case managers in 5 different places who are sort of like, I can take you to here, and then I can't take you any further. And I can't even warm handoff you to the next group. I can tell you, you might want to call them. Right? And so I think if we can delve into that, and then maybe that will give us a sense of, okay, well, let's talk to this cohort of folks and this cohort of folks.
And can we talk to how we can reduce those barriers, right? So even when you are, so for instance, like with the community health workers, great like liaison between the organizations and between the communities, run into the roadblocks, right? Because of all those things that you just mentioned, Jill, then there's this, I can't share that information with you because we're working for the same person. You know what we're doing here. I cannot share that information with you. And it's like,
Right.
And then the person, you go back to the person and you've met that roadblock, they lose hope. Then what am I supposed to do if you can't even get me any further? And then what do? Drink more, drug more, depression, right? And so we send them spiraling too, because we were supposed to be the help. We were supposed to be the advocate. We were supposed to be the bridge. And we get there and we can't even get through the door. So can we focus on looking at, you know, how we can reduce some of these system barriers, and some of that's going to be at the policy level, because there are policies that state, I can't talk to you about so-and-so, even though we know, and we're public health, we're supposed to get information.
Right.
I can't tell you that because of
This
141, but it was like, ugh.
You just made my day. I'm not retiring now because I don't have any barriers. I can. All right, fine, I'll keep working. Ruin my wife's day, but that's okay.
So can we focus on that? Because we have a lot of resources. We just have so many system barriers, and we've identified all these things. And, you know, this list here has been the same list we've been doing our community health assessment for like 12 years. These things are still the same priorities. Nothing's changed. So I don't think it was an exercise in, you know, just like that we didn't need to do, but we need to get to what's our problem and how do we solve the problem? How do we make it so that we can actually be effective at the work that we're doing with the communities that we serve? So they don't have 5 different people that they run into and everybody's telling them something different.
If you ever like sat down and done like a systematic outline of what all the barriers are, And the only reason I mention that is in my world, we, one day, you know, we're saying we got all these barriers and nobody ever really identified what they actually were. So just went down and did it. And then I probably should have published it, but I didn't, but it made like a huge difference in how like we as a group, like this was a hospice exercise, but you know, how we dealt with all that. Cause until we really knew what we were dealing with, we really didn't know what we were dealing with.
I mean, I will say that I think, and maybe this is a place where we can bring some of these folks in to the next conversation. I do think that in creation of some of those state plans, some of those barriers are pretty well known. So like the state plan on aging, for example, did try to articulate a number of those barriers that limit, again, you know, I think the recognition that there are many social service infrastructures that have been built and they're built for a purpose, not a person necessarily. And not to say that the person isn't important to the folks, because they certainly are, but they're met, I mean, I think nutrition's a good one, like this is a food-focused issue, right? And so if you are a food-focused person and you go in and you find out that person also is a fall risk, you don't have the capacity to do anything about that. You got to bring that over to the fall risk people. Right, so they're purpose-centered systems, not person-centered systems. And I think anybody working in them is frustrated by that. And I think those were articulated pretty well in some of the state plans. So I think it's a good point to bring those back forward. And to your point, Bobby, I think we've heard the same barriers over and over and over again, which doesn't mean we shouldn't talk about them, but maybe we should bring them forward again. Because this is, maybe we can bring them forward in this group in a way that they haven't been before. So if folks feel like that makes sense for the next meeting, we can work on trying to figure out who those people are to bring forward. Again, I think, you know, Becky, you could talk a lot about trying to deliver services when you're funded in this stream and funded in this stream and funded in this stream. And then we can wrap around some of the folks in some of those other systems too and start that conversation, if that makes sense for folks for the next meeting. Okay, Josh, did you want to say something? I saw you come forward and I just wanted to make sure we were respecting the fact that if you came off camera, it might mean something.
No, thank you for asking.
Okay. All right. I know we were supposed to go to 2:30. I know some folks have conflicts and a lot of folks have dropped off, so I want to be cognizant of time. So we'll work on that as the next conversation and figure out who the speakers should be. I'll get the slides that Whitney and Alia sent probably early next week, because I'm not sure I'll have time this afternoon. And then set up our time in March. I know Polly, I may want to ask Polly to do a little bit of presentation because a lot of these issues that we talk about around social service infrastructure and barriers is in the older adult population. That's where it's largely demonstrated. And that's her area of expertise. And this time might be hard for her. So you may be getting a request to move a half hour before or after. So I'm going to connect with her about that. Any last questions or comments before you go out on this nice spring day? I mean, just kidding. 50 degrees, I think. All right. Thank you, everybody.
Thank you. Bye, everyone.